Thank you, Professor ZIENIEWICZ and Professor BISMUTH for inviting me to present this case. So this is a 50-year-old woman who was presented to the tumor board, a liver tumor board, weekly tumor board, with a 15.2 centimeter mass, and you will be just like at the tumor board in Houston with this case. She had some fatigue and inability to exercise, but what led to the diagnosis was really abnormal liver function test. She had a CT because of this alkaline phosphatase of 1278. She had normal bilirubin, ALT, AFP was normal. She had no history of hepatitis, no oral contraceptive use, and she was presented by our hepatology service with the following imaging. And maybe you want to comment on the imaging. Some of you here, obviously this is a large tumor. You see this large tumor in the left liver, and a relatively small right liver. There's a cyst also, part of the right liver, and there's a vascular malformation here you could see. So I'm going to ask you what you would consider in a patient like this. Would you consider transarterial? I can come back to the imaging. Transarterial embolization, resection, transplantation, venous embolization, or biopsy of tumor, or several of the above. You could choose A, B, and D, or B and D, or D and E. So I'll let maybe the moderators discuss this a little bit here.
Well, we see a very large tumor on the left lobe of the liver. We really don't know what it is. So the question is, what are we dealing with?
All right.
Any suggestions from the audience?
So we did a biopsy which showed hepatocellular neoplasm. And in fact, the hepatologist came to the tumor board with a biopsy, hepatocellular neoplasm, and nothing else. There was no no definite diagnosis. I was very worried about maybe a potential for malignancy. Maybe it could be an adenoma, well-differentiated hepatocellular carcinoma. So we asked for beta-catenin, and it was negative. So I was not so worried. We even did a special study for CT and NB, and it was negative also. So was not too worried about malignancy, but still worried.
And the markers were negative?
The markers were negative. Negative AFP, negative CA19-9, negative CEA. Would you consider resection here, or consider other studies?
Hi, yeah. Nick. Hi, Nick. This is Daniel.
Yeah, hi.
Cherokee. Hi.
Hi, Daniel.
What about this splenomegaly? Any signs of portal hypertension?
Well, there were no collateral, but there was a large spleen. There was a large spleen.
Isolated large spleen, no collaterals.
Yeah,
right?
isolated large spleen.
Remind the age, the patient's age.
55.
50.
50.
50 even.
The splenomegaly doesn't fit in the picture. You need to, at the biopsy was only of the tumor, or also the non-tumor liver?
Biopsy of the tumor.
Okay.
So I was at the tumor board. I was leading the tumor board. So I'd like you to lead the tumor board now in Houston, because I had to make a decision on this. Fairly, we have about 40 or 50 people at the tumor board. What would you do next? Or what would you recommend?
We might want to go further in the diagnosis process, and if they cannot reach a diagnosis with the first biopsy, maybe we should do a second one, and including a biopsy of the non-tumoral liver.
Yeah, I didn't order that, but if it had been ordered, it would probably have shown normal liver with probably some atrophy of the hepatocytic plates.
Pietro, MAJNO.
Yeah, I mean, if it's not an HNF, then it should come out. Stop.
It should come out, okay?
Should be resected, yeah. I mean, even if it's an adenoma, non-beta catenin, whatever, it's larger than 4 centimeters.
That we can debate, Pietro. I think we are more and more conservative with the adenomas, even when they are larger than 4
the guidelines
5 centimeters.
adenomas are quite clear, larger than...
larger than 5, yeah, that's what
I'm happy to discuss that. I'm not sure that
say.
everybody currently takes out all adenomas larger than 4 and 5 centimeters.
I agree. I don't think there is any recommendation for weight loss, any recommendation for arterial embolization.
None.
Weight loss, she's already thin.
That's out.
She's functioning at lower power, this lady, with this. Okay, so I'm going to show you this. This is it here. She has a hypervascular mass in the left liver, and she has this malformation between the left portal vein and left hepatic vein. And as you can see here, left hepatic vein, left portal vein, left hepatic vein was very, very enlarged. She had a small right portal vein, and in fact, atrophy of the right liver. And these are the mutations we had, and they were negative, not suggesting malignancy by any means. So I was kind of reassured by this. So what would you do next in this case?
So Nick, sorry to interrupt. It's Hugo. How are you? Nice to see you.
Good, Hugo. Nice to see you.
I would like to know that, so you did a biopsy. Abernethy malformation is connected to several tumors, including hepatocellular carcinoma. You couldn't go further in the biopsy besides well-differentiated hepatocellular neoplasm. Is it an hepatocarcinoma or not?
Right. Yeah, I couldn't get further. I couldn't get further.
No, but
my
Abernethy
sense when I
syndrome,
get this, yep, go ahead.
Abernethy syndrome includes no portal vein. Does she have a portal vein?
So she does have a portal vein. You see that right
we need to know more
here?
here.
I can show you with it. You see that right portal vein? It's very small here. This is the left portal vein. This is the tumor here.
The main portal vein.
Yeah, yes, there's a main portal vein. Yeah. So there's a main portal vein, and there are two types of Abernethy, and as you're saying, Danielle, here, there's two types here. There's this one, the first one, and there's this one, the number 2 here, and we have a number 2 here. We have a number 2, type 2 Abernethy malformation. I've seen 2 cases. I've seen number 1 and number 2. Usually they present in children. So, but you know that some patients never get diagnosed as you know, in childhood, and so I've seen the hepatocellular carcinoma in the type 1, and I've seen this one. So what would be your recommendation here?
So this, number 1, this explains the splenomegaly probably in the context of a small portal vein, and so I'm happier when I understand what's going on. And I've seen cases of type 1, type 2, I don't remember. But in any case, I agree with you that it can be associated with HCC. So, and it seems to me that you can do a parenchymal preserving resection there.
Okay.
I mean, it seems it's only segments 2 and 3, or does it involve also segment 4? I can't see that really from those images.
It'll be 2, 3, 4. There's this big venous lake here.
And it's going to be tumor only, right?
Yeah.
It's going to be tumor only. You're going to remove tumor only.
Yeah, you could remove tumor only, but you would remove, you would remove tumor, and you wouldn't know exactly where the margin would be here. I think it's kind of a I didn't show you all the cuts. I should go over the cuts up and down, but obviously this is, the margin is going to be concerning. I mean, I'm worried about the enucleation, and it's a well-differentiated tumor. If it's a cancer, it's well-differentiated. So it's an emergency of the mind. It's I don't rush this necessarily.
If this is an hepatocellular carcinoma, probably the best treatment would be liver transplantation. Have you considered that also?
It was in the list. I think it was number D. It's one of the answers, Hugo, but we didn't transplant this patient.
No, that may be a second option. I would resect this case if, of course, we don't see all the images. The question, I would be concerned about doing an embolization before, because I don't really understand how the portal flow works. So I would bring the patient to the operating room, get a complete resection of this tumor, and we'll see. The margin may be an issue, but you will have the specimen and you will know. Don't get inside the tumor, remove the whole tumor, possibly with the margin, and then you get the full, and then you'll know if it's cancer or not, and you go on with that.
Right. I mean, that could be an option, certainly, but don't get into the tumor and don't get into the shunt. That's the other thing you don't want to do. So that's what we did here. We did occlude the shunt and measured the portal pressure, same as right atrium before the occlusion, and the occlusion was performed with Amplatzer and coil embolization, improved right portal flow, post-occlusion portal pressure, 20 millimeter mercury. Okay, and that's 6 months after the occlusion. So the tumor decreased in size from 15.8 to 11.3. There was an increase, a marked increase in the right liver volume and right portal flow, and AST and normalized. Alk phos went down to about 200. So I was fairly reassured by this, but in fact I presented the case. This case in Mexico City, I think 2 years ago, and I asked the following questions now. What is the next strategy? So the tumor is much easier now to resect, it's I guess it's a cheap shot. So would you do
why don't you include open resection here?
I haven't. Because I don't, because it's easy.
Nick,
it would be very easy for you, Daniel. Yeah. What would you do open? Yeah.
Nick, have you done any volumetry to see what is possible to do with the resection? Because I see that the left lobe is very, very big now.
Yeah, the left lobe. So what's here? I think I have to say that what's here, there is some volume averaging with the pancreas. The liver is right here. See, it's right here. But we did some, I'll show you some volumetry, in fact, in a moment. René, I think it's a good question. I'll show you volumetry of the tumor. I'll show you volumetry of the right liver in a moment. So,
Just a comment on laparoscopy or maybe you want. When the tumor is bigger than 12 centimeter, I'm not sure. It's of course if it's a hanging tumor, which is an exophytic tumor, it's fine. But this one is not really exophytic.
Okay. So I should have added open resection probably. Okay. All right. So that's go ahead.
No, I was just saying it's a likely candidate for resection. I think our limit for minimum invasive resection, if it's a tumor too big to fit in the bag, because that way you will have a lot of trouble managing it, I think.
Okay. Certainly with a fine and steel, it's not going to be fun. Okay, so I'll give it to you now. Okay, so 24 months after shunt occlusion, 5.9. Increase of right liver volume and right portal vein flow, AST normalized, and what was remarkable is that the patient, she was functioning at lower power without even knowing it. And she said, my life has changed completely. And I can exercise now. I'm on the treadmill, I'm jogging outside. And so there was a temptation, I have to tell you, at 6 months to resect this tumor. But I didn't feel compelled to resect it. If it had been a hepatocellular carcinoma, it would have grown within a month or 2 or 3 of the occlusion of the shunt. So I didn't feel compelled to resect it, really. And when it's well differentiated like this, I think cancer becomes an emergency of the mind, especially if it's not for sure a cancer. And this is a change in volume, which is quite remarkable. Here, she had a very, very small right lobe, 300 cubic centimeter on admission, a very large tumor, no flow in her right liver, and this was reversed with the occlusion of the shunt. And the left lobe increased in size also, interestingly. So regained some function, as you noticed. Okay.
I have one question. Yeah, I have one question concerning symptomatology. Those kinds of shunts may be correlated with hepatopulmonary syndrome. Did you analyze the pulmonary function and eventual pulmonary hepatopulmonary syndrome in this case?
No, we didn't. In fact, the fatigue, I presented the patient as being fatigued initially. Initially, this was not her complaint, but retrospectively, following after 2 years after the procedure, she said, I'm another person. So, and I can do all these things, and I didn't realize I could do it, and I didn't realize who I was. So anyway, we love the liver. It's the power station of the body, and it was a striking example of a shunt and a change in a lifestyle.
Professor Vauthey, did you repeat the biopsy now? Because the first biopsy should give you an nodular regenerative hyperplasia. Because these patients with Abernathy syndrome or Abernathy-like syndrome, they have normally normal nodules regenerative. So probably the first biopsy was not correct, and the patient should repeat the biopsy. Now, after the occlusion.
You mean the biopsy of the tumor or the biopsy of the non-tumorous liver?
The biopsy of the pseudo-tumor, because it's not a real tumor, that I think. We see that on pediatric age in some patients. And the biopsy is mandatory to decide if you are going to operate the patient to resect the tumor and to treat in the surgery the Abernathy, or if you are going to only treat the shunt by radiology and do nothing to the tumor. And what should give you what to do is the result of the biopsy. So what I think is that the first biopsy is not completely correct, and it should be repeated now.
I think you have different stages in this disease. You have the nodular hyperplasia, which starts with the essentially arterialization. The shunt, caused a hyperarterialization of this left liver, and the tumor started growing there as a focal nodular hyperplasia, and then became this hepatocellular neoplasm of large size. and then could turn into a hepatocellular carcinoma. So I think there are different stages here, and I think it's not black and white for the pathologist in this disease, but we recognize several stages, and I think that was the stage we indicated here was more like adenoma type of picture and not nodular hyperplasia.
Nick, very nice case. The shrinking of the tumor, of course, was a reassuring point. What was the intention at the beginning when you embolized the shunt, closed the shunt? Was it to bring the patient to resection, or just you knew what would happen?
Yes, the intention was to resection.
Okay.
But when I saw the improvement, and the first, you can wait 2 to 3 months. I don't think you change the prognosis in a lot of tumors, especially these well-differentiated tumors. Follow up 2 to 3 months, and that's what we do for benign tumors. We follow them. The first follow-up is 3 months, then we say another 6 months, and then another year, and we stop following them.
We know that this is a vascular reaction of the liver, and not a real tumor, because it's shrinking. But it's FNH-like type of thing, and it's a pseudotumor, but because it's shrinking. But you're going to follow up still. It's very nice. Thank you.
Yeah. Thank you very much. Thank you.
Thank you very much. Appreciate that.
Welcome.